Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and today we're tackling a topic that made headlines across the UK and Europe earlier this year, and that is the significant and somewhat puzzling rise in scabies cases. So data from the Royal College of GPs Research and Surveillance Centre have shown a significant rise in cases over the past few years. And the college adds that while case numbers nationally have fallen over recent weeks, they do remain stubbornly above the seasonal average, and inevitably this will have a knock-on effect for GP workloads. So I'm delighted that today we've got Dr. Claire Fuller here with us to put this into context and to give us some tips for managing the burden. Dr. Fuller is a consultant dermatologist in the UK and co-founder of the International Alliances of Scabies and of Global Health Dermatology, and chair of the scientific committee of the World Scabies Programme. So welcome to the Clinical Update podcast, Claire.
Thank you very much, Rhiannon.
So I mentioned just then these quite startling increases in the cases of scabies in the UK. So from your vantage point in the UK and also globally, what's your take on this? Are the numbers as concerning as they seem to be?
Well, I think the most challenging thing about scabies is that it's not a reportable condition, so we don't actually know the accurate number of cases. So I imagine the data that you're seeing or hearing about from the Royal College of GPs is going to be a little bit surrogate. It'll be on the basis of the sales of anti-scabetic drugs, potentially, and the only other kind of hardish data we have is from sexually transmitted infection clinics who actually do record things a little bit more clearly. But there's definitely signalling that the cases are increasing nationally and actually across Europe, and we've been seeing a real surge in cases, and certainly in my own clinic. So I've been obsessed with scabies for about the last 20 years, and that's been on an international public health capacity, looking at scabies in remote parts of the world and particularly in the Western Pacific. But I would be sitting in my NHS clinic over the last few years until I retired, not seeing a case as a secondary care provider, or very occasionally, 1 or 2 cases a year. And now I'm seeing 6 or 7 a week of people who are struggling with difficult scabies or think they might have scabies. So it's certainly become a huge theme. And I think that just reflects what is going on in the country. So the question would be why? And I think we don't really know why. So if you look back historically at estimates on variations in the amount of scabies that goes on in the world, it does tend to be cyclical, and that is the assumption. I don't think we can say any more than that. You get to a situation where you have a bit of an outbreak and it just gets going for reasons that are not entirely clear. One of the reasons that was blamed in the UK was rather sweet. It was post-COVID, young people getting back together. It seemed to be that the index case in a lot of outbreaks have been in secondary educational establishments and universities, and that is just a reflection of potentially young people getting back together again, and that may be why it happened, but we don't really know exactly why.
So you mentioned then that you're seeing, or you were seeing over recent years, a significant increase in cases that were coming to you in secondary care. But in terms of actual diagnosis in primary care, is it challenging to pin down? I've certainly read some reports about patients feeling frustrated by misdiagnosis. And have you got any thoughts on that?
I think the most challenging thing is that we don't have a point of care test. It's not like taking a blood pressure or doing a blood sugar level. You get an answer. It's either abnormal or it's normal. The challenge with scabies is that it's a clinical diagnosis, and to make a definitive diagnosis does require a little bit of skill. And if you haven't seen that many cases, then you might miss it. So we were involved in the International Alliance for the Control of Scabies in producing some guidance around diagnosis. So we produced some consensus criteria on diagnostic criteria for scabies and came up with a range of approaches. So whether you are a definitive diagnosis, that you've seen mites and mite parts, which you need a bit of microscopy to do so, and that's either with a dermatoscope or taking a scraping and looking at it down the microscope. Or you can make a diagnosis of scabies on the basis of the patient's been in touch with somebody who's got it and has the appropriate symptoms, so they're itching, and has some evidence of features, clinical features in body sites where you would expect them to, such as the interdigital folds around the wrists, over the breasts, over the genital area, under the arms, and particularly over the genital skin, like the penis and scrotum. If they've got nodules, that's very, very suggestive. And so you make it on those grounds, and that is sufficient to then make a diagnosis and instigate treatment. So I think a proportion of GPs, those who have been enthusiastic with their dermatology, may have a dermatoscope and be able to look for burrows and look for features of scabies that way. But others will be making the diagnosis on the basis of itch, and often much more itch than you're seeing the lesions. So you'll see someone who's really, really itchy, and mostly all you can see are rather non-specific scratch marks. But then if you do have some helpful signs around the wrists and in the interdigital folds, that can really point you towards scabies. I'm also obsessed with feet. I think looking at the patient's feet can be really helpful because often the burrows that will be there are a bit easier to see. But so I think in summary, if you're going to examine the patient, and it does involve taking their clothes off, I'm afraid. So it's hands and feet and trousers down. Just that will then help be confident that you're not missing scabies. So that's in adults. In children, they often have little pustules or vesicles on their feet. So they don't necessarily have classical burrows. But often if you've got a child brought in by the parents, the parents will have the physical signs that will be common in an adult. The child may have these little vesicles around their feet, and that can be helpful. And then it's more tricky. We've seen some data in elderly patients where the features are very different and very vague. So you just might see some non-specific scratch marks in covered areas. So again, that involves undressing, which, typical features for scabies you would anticipate making from looking at someone's hands.
So what would be the current recommendations for management? And is there any advice that clinicians should be giving patients around how best to manage the condition?
Advice that we produced from the British Association of Dermatologists, I think it came out around 2023, a bit of an update on scabies treatment, is that, ivermectin is now licensed for scabies, and I think it's so much easier to take than applying permethrin. But ivermectin and permethrin, so ivermectin is oral and permethrin is topical. Both of them in head-to-head studies are as effective as each other, pretty much. So if you're going down the topical route, let's think about permethrin. The most important thing, as well as giving the patient the recommendation for how much they should use, is to provide them with written information or direct them to written information. So typically, if you just tell the patient how to put the treatment on, they invariably don't do it correctly. Even if you do tell them how to do it, it can be challenging to put on topical treatment effectively. So the recommendation would be you apply the treatment on day one on a clean body. So they've had a bath, they've particularly scrubbed under their nails because that's where the mites tend to sort of lurk quite comfortably under nails. You apply the cream all over the body, focusing particularly on the sites where they're most likely to have active mite activity, which will be around the hands and the feet and the scrotal area, particularly under the nails. And you apply it. A lot of the instructions say you apply from the neck down. I always include the head and neck now. I just don't think there's any reason really not to. And you apply it on day one. They go to bed in their normal sheets that night, wake up the following morning and reapply it to the whole body without washing off last night's, and then go through the day, reapplying it during the day every time they wash their hands, and wash it off sometime after that. So the license says, I think, around 8 to 10 hours. But I think if you leave it on for 20, you're kind of doing nearly 24, that's going to be the most helpful. And then the evidence base for recommending going to bed in clean sheets is not huge, but I think is what we should be advising. And that's certainly what I advise, is that the patients go to bed into clean sheets that night. And then they have to repeat the whole process a week later, because neither permethrin nor ivermectin are effective against the eggs. and therefore you will have a hatching out of any eggs that have been laid, and you will need to capture those hatching out over the next week. So that's the treatment of the patient. But the most important part of managing scabies is treating the close contacts of that patient. By close contacts, it means people that they share a house with, people they're in close physical contact with, relatives who they might have spent some time with and then come back. The kind of typical scenarios, you'll have your family, they've all been treated, but you've forgotten that one of the children goes to stay with granny and grandpa, and granny and grandpa have been infested, and so they go back again, and then they just bring it back into the household. So it's thinking carefully about contacts are really important. Emphasizing the application twice on day 1 and day 2, and then repeated the following week is really important for permethrin.
It's not surprising, really, is it, that patients struggle, because it's a very involved process and a lot of steps, and the reapplication, and then particularly, I suppose, if you're doing that with children as well, it sounds like it is challenging for patients.
I mean, it's not just challenging for children. You imagine if there's an outbreak in a residential care setting with elderly, frail people who may or may not be a bit confused, and try wrestling them and to get all of their treatment on. It's a really tough treatment, the topical treatment. And that's why ivermectin is such a godsend, really, because the ivermectin is you take the tablets on day 1 and then you repeat them again 7 days later. The thing that's a little bit confusing for GPs, I think, is the way it's expressed in the British National Formulary. It says you take the treatment on day 1 and then you see how they are 7 days later. I think we need to revise that. It's a bit confusing because they may be feeling better in a week, but actually they will still be hatching out their eggs that they haven't got rid of, and therefore they will definitely need 2 treatments. So the treatment for ivermectin is on day 1, and then days 7 to 10 needs to also happen. And then the other thing that's really critical for ivermectin is getting the dose right, because it's dosed per body weight. And it's 200 micrograms per kilogram. But if you're in a rapidly short clinic with very short appointment times, and you're a bit like a rabbit in the headlights with the maths, I quite often like to have a chart, if you're seeing lots of scabies anyway, a little chart of how many 3 milligram tablets do I need to prescribe for this patient who weighs this amount. There are lots of charts around to help you do that. So I think that can be quite helpful.
Yeah. And then in terms of their environment and making sure to wash all of their clothes, all of their bedding, all of that sort of stuff, that's something that primary care will need to be emphasising to people as well, is it?
I mentioned that we don't have great evidence base for that. And so, for example, in the big population-based studies we've done in the Western Pacific, where an island was randomized to receive ivermectin or permethrin, the populations don't have access to maybe another set of clothes or even a washing machine. They won't have an access to a washing machine, and they won't be changing. And managing your fomite control, which is technically called, if you don't do it and you do a population-based intervention, actually most people do pretty well. But given that we're mostly seeing people who aren't doing well and are having ongoing disease, doing the fomite control is just something that I do recommend, because then you're absolutely clear that you're doing it. But if you can't wash everything, and that's too much to do, you can actually put it in a plastic bag for 3 to 5 days. And the mites are very frail. They don't live off the body successfully. So if you just put your sheets into a plastic bag, you could then use those again in 3 days. You don't necessarily have to wash them all again.
Yeah, absolutely. So you just said then that the people that you would be seeing would be people who are not responding to those standard treatments, persistent or recurrent disease. And what are the options?
Well, I think what tends to happen is that they come to see me and they say, oh, I think I've got resistant scabies. I've had 20 rounds of treatment. But when you drill down with the history, you can normally find that it's actually not resistance of the drug. It's, I would call, pseudo-resistance. It's actually treatment failure because they haven't been advised correctly on, or they haven't taken on board the advice around contact tracing. They said, oh, none of my flatmates had any symptoms, so they didn't need the treatment. And it's a hard one because it's a stigmatizing condition. People self-stigmatise that, oh my goodness, I've got this disease that means I'm a dirty person or whatever, which it just doesn't. It's the most, it's actually a very sweet little mite down the microscope. If it didn't produce such symptoms, you could think it was rather lovely. But people do self-stigmatise, and they really are challenged in persuading their contacts to treat. For example, in a university setting, what I tend to suggest is that if you've got or a young people setting, if you get the index case who's come to you, who's in a terrible state, and you say, right, well, you've got 3 people in your household, go and buy them the permethrin. Here's the patient information leaflet. You give them the amount of permethrin they need plus the information leaflet and explain why they need to treat and that you're providing them with the treatment because it's your interest that they get treated appropriately. And that can be a kind of helpful way to do it. Obviously, you can't prescribe tablets for somebody who isn't your patient, who you've never met, but you can do that. The patient can buy permethrin over the counter. That's an approach. But I mean, as we've mentioned, it's a challenge to put cream everywhere. There was a really interesting study from Austria that looked at telling the patients how to do it. They then gave them some fluorescent cream that they had to go and apply as though they were applying it. And then they were checked with this fluorescent light to see how well they'd done it. And they had basically, even with that very, very strong advice, emphasising application around hands and feet, they'd missed all the areas that they were supposed to apply it. So it is really challenging to get it right.
That reminds me of when you were a child and you'd go to the dentist, you'd chew that purple tablet, that pink tablet, so that you could see all the bits that you'd missed when you were brushing. And it was always much worse than you expected.
And it's similar when we do our hand washing training. You know, you could think you've done your hand washing really well, and then you see all of these bits all over. So topical treatments are tricky to apply. I guess one area we haven't talked about is children. One of the sort of challenges is what do you do for small children who are technically too small for the size of being allowed to have ivermectin. I firstly would say that body weight size is coming down. The data emerging from various studies across the world is confirming what we know, that ivermectin is a really safe drug and is well tolerated in all age groups. It won't be long before it will be licensed for all age groups. But permethrin is usually pretty well tolerated in all age groups, and that's really not a problem. So that's what I would normally recommend. And if you look across Europe, benzyl benzoate is another alternative. It's not available in the UK very easily at the moment at all, so it's not practically available for humans. Patients are resourceful and they can find it in other ways, but a 25% solution is what's recommended. And that's applied on 3 consecutive days. It's sort of slightly different from permethrin. And it's also ovicidal, so it doesn't need to be repeated. It's sort of easier that way.
You just mentioned children then, and it might be worth then talking about any other sort of groups that are at specific risk. So I think you said earlier that in older people, it often presents slightly differently. And are there any other kind of considerations, around people who are immunosuppressed, for example, things like that?
Yes, absolutely. So if patients are immunosuppressed, they probably won't develop symptoms or be itchy, and they'll just quietly have little mites proliferating on them. And so they may present with a rash that looks a little bit like eczema. And so you could find yourself with a rash that looks a bit like eczema, putting steroids on your scabies. And so you end up with somebody with crusted scabies, which just means that they've got loads and loads of mites. Somebody who's itchy and has the symptoms of scabies may have maybe up to 10 mites, and that's the maximum they'll have. Whereas somebody with crusted scabies may have millions of mites on them at any one time. So if you've got a crusted case, you've got a super spreader who is spraying mites everywhere, and so they're very, very easily transmitted to other people. I kind of feel you haven't arrived in dermatology until you've missed a crusted scabies case. They can be really challenging to diagnose. But I mean, going back to, what's the challenge? So that's your immunosuppressed patient. And I think that also is what's really happening in the elderly. The immune system won't be quite so strong. And more than 50% of elderly patients with scabies, and this is from a study that was published in Lancet Infectious Diseases, are asymptomatic. And only 40% will you be able to find burrows. And only 11% will you actually see the little mite at the end of the burrow. So, it can be quite difficult, and often the signs are on covered sites. And that study demonstrated that actually dementia is a risk factor for scabies. So, they're more likely to have it misdiagnosed. And then there's data that suggests in children, about 50% of cases are missed. That can be challenging too. So it's difficult to make the diagnosis sometimes.
I'm quite staggered actually about the difference in the number of mites that somebody could have. So you've obviously done a lot of work around neglected tropical diseases, and I hadn't actually realised that scabies is classified as one as of 2017. So Thinking then from a global perspective, we just talked then about some people that it might affect disproportionately, but might it also affect marginalised groups who have perhaps limited access to healthcare? And how does that translate into a UK context?
Oh, that's a really good question. And from the point of view of the neglected tropical disease status, that was the thing that we were so keen to get accepted. And so we were delighted when the WHO accepted the submission and awarded this accolade, because it increases the opportunity for advocacy and funding for research and so forth. What we see is that scabies loves a nice overcrowded situation. So we're calling it a migration crisis, but migration's been going on forever, but we're just aware of it particularly being something that has been a particular of interest in Europe over the last decade or so. So in displaced persons camps where people are stuck together with very limited access to water and washing facilities and general hygiene facilities, that's a perfect storm for scabies to be able to be transmitted. So you're absolutely right. It is a real reflection of equity of access to healthcare and even basic social determinants of health that they haven't got access to. So I think patients on the move are really at risk. And then when patients are on the move and then finally settle at their destination, if they maybe come into a reception centre or however it's being handled, again, they're going to be in an overcrowded situation, arriving with whatever many people have had very difficult journeys and have picked up all sorts of things on their journeys, which might include scabies. And so being aware of that is as an important consideration in how we care for those who have had a really troublesome entry into our medical care. So there's those on the move in terms of migration, but then there's also those who are marginalised in the sense of people experiencing homelessness. They are going to have limited opportunities to be able to have access to hygiene, to washing facilities and so forth, and also will be potentially having relatively intermittent close physical contact with each other. So that's certainly something that has been identified as an issue in certain Austrian studies have published specifically on scabies being an issue. Access to care for those experiencing homelessness is challenging for many medical disciplines, not just dermatology.
I mean, are there any practical things that can be done for somebody who may not have access to washing facilities, like we said, things like that? Are there any kind of pragmatic adaptations, I suppose, to the normal treatment regime that people might be able to do to be able to help?
Well, I think that's where probably ivermectin comes in. Ivermectin is such a useful drug. It not only treats scabies, it treats about 4 other neglected tropical diseases. Not that necessarily you need to do that, but it is a safe drug. It's very easily available. The thing that's not so practical in a setting where you're a bit disadvantaged or you're only going to get one go at them, if you see what I mean. It needs a repeat dose in 7 days' time. And so what we're looking forward to is a longer acting version called moxidectin, which is actually now got a human license for onchocerciasis and is being worked on, getting a license for scabies is being worked on currently in Australia. We don't think that'll be too long before it will be available. That's encouraging.
Yeah, that sounds very promising. So finally, looking at the bigger picture in the UK, primary care workload, are there any changes that you would like to see in terms of how the NHS manages scabies? Or is it really a case of looking ahead to the development of this new treatment option or some new treatment options that might make this easier to manage?
Well, I suppose before answering that, I just put scabies into its context in sense of its impact on general health. So it isn't just a mite that's a bit itchy and that it's worse, it's socially stigmatising or disturbing sleep. It has a huge impact. So we know that scabies, with its severe itch, does lead to stigma and social isolation and sleep disturbance, and then absenteeism from either work or education, and so has economic effects. But it also, because of the irritation and the scratching, it leads to a breach of the skin barrier and has some local host immunity effects, which can lead on to secondary infection, so impetigo with either staphylococcus or streptococcus. And those two cutaneous bacterial infections have measurable sequelae. Either you can get a significant soft tissue and skin and soft tissue infection, you could get septicemia, You can get immune-related disorders like rheumatic fever and glomerulonephritis, which can have long-term impacts on cardiovascular and renal health. I emphasise those in terms of it isn't just a skin disease. So I do think we do need to have a conversation with ourselves as a National Health Service as this does seem to be, a significant issue. What are the options? How are we going to address this? And if we are going to be pragmatic, are we going to have a campaign that says, if you're itchy and you've been in contact with scabies, this is the treatment, and you just buy it yourself? You don't need it diagnosed by the GP unless it's failed on permethrin, in which case you come in with access to ivermectin, and for the GPs to feel very comfortable about prescribing that, and I think they are increasingly comfortable about prescribing that, and I'm not seeing many patients having that not given to them. Anything where you've got an emerging rising cases is going to significantly impact on workload. So finding a way of producing some interventions that bypass the need for the patient to come to the GP in the first place seems to me a practical approach. And from the point of view of international health, it's interesting to note that just in May last year, the World Health Assembly passed a resolution recognising skin disease as a global public health priority. And WHO resolution has a number of recommendations which include capacity strengthening skin skills or dermatological skills worldwide, and recognising the severe shortage of frontline healthcare workers. And so prioritising also the development of self-help information, high quality education for patients and communities. And I think that's potentially where we should be potentially focusing. And we certainly are internationally. I'm also on the board of something called the International League of Dermatological Societies, really catchy. We're just launching a skin learning hub, which will have access to high quality education for these different target communities.
It seems like an option where capacity strengthening, it's like taking it a step back, isn't it? And really empowering patients before you get to that point to manage that burden.
One of the things that is deeply frustrating, I've been saying, we haven't got access to benzyl benzoate. Ivermectin is quite difficult to get hold of. Actually, ivermectin is quite expensive, whereas internationally, it's as cheap as chips. It's a generic drug. It should not be as expensive as it is. So I wonder whether we can use this international political mandate that the UK signed up to, because it was unanimously went through the World Health Assembly, to say, look, perhaps we should have a policy discussion around making drugs available for scabies, which we should consider as a public health priority. And it's becoming a public health issue in that it's significantly common now to be having a significant impact across the country. And so is this the time to have the conversation to ensure that we do have benzyl benzoate available? It's a drug that's been around for centuries. It's something we should be able to have access to. Can we have a tough conversation with the pharma providers of getting the price of that drug, of ivermectin, down? These sorts of conversations, I think we want to use the political mandates we've got to translate into impacts for patients at the front line.
Absolutely. That's a great place to leave it. And I think it will leave us with a lot to think about. So thank you very much, Claire. It's been really great to talk to you. Don't forget that you can claim CPD credits for listening to this podcast. So you just head over to mimslearning.co.uk to complete the associated module. This episode was produced by Jude Owen, and we'll be back again next week. So I hope you'll join us then.